So Bill, here's a case for you. The details of the case are that she's a 27-year-old female. 6 years ago, she had surgery elsewhere. She had a periareolar mastopexy. She had submuscular augmentation with saline implants that are high profile. She comes in my office now, 6 years after surgery, no other changes. She had had one baby before her surgery, but nothing else. Smaller framed individual, not a lot of breast tissue. She states that she never really liked her surgery. She never really liked the results of her surgery, which is unusual to hear that. She didn't like the look of her breast. She didn't like the feel of the breast. She thought her nipples and breast mounds did not line up. She thought that the implants felt strange. She thought her breasts looked weird when her chest muscles would animate. She thought her breasts were too far to the side, and she thought her left breast was too low.
Craig, I mean, this is an incredible case for education because, I mean, we could talk about this literally for like 5 hours, how many things there are to talk about. You know, and I'm sure you see this as well. Everything in breast surgery, just some basic tenets, is about precise surgery, doing things under direct vision. So, you know, this whole thing, you said she had a periareolar approach. In general, I see a lot of those patients and they don't have precise surgery, and so their muscle is either missing or over-released, which is a big problem in itself, and I think one of her primary problems. She obviously has malposition, which is another, it's the second most common risk if you look at the FDA studies, long-term risk and for reoperation in breast surgery. So she's got a malposition, worse on the right side, but really lateral and probably a little inferior malposition on both sides. You know, the hyperanimation you described is obviously from over-division of the muscle, releasing the muscle too high, improper dual plane technique, and again, that probably has to do with not being able to do things precisely. I'll be interested to see what you ultimately did. But the way I would approach this would be to kind of obviously discuss with her, you know, what the issues are, and then in terms of options, I mean, the primary thing that she's got is she's got an over-released muscle, and then she's got the malposition. So we've got to correct that. Number one, I would not correct it back through a periareolar approach. She needs to have kind of the Ferrari approach, which in my opinion is an inframammary approach. And we're going to correct the malposition. You could do one of two things. You could do a neosubpectoral pocket, or you could do just capsulorrhaphies. I probably would do capsulorrhaphies in her. When you do that, I like to add, these patients have issues. You know, they don't want to have reoperation. So, you know, you can do a capsulorrhaphy or a neosubpectoral pocket and get a good result. But if we add some soft tissue support to that, then that can help bolster that, minimize the chance for reoperation. So I would do capsulorrhaphies. I would do a little capsulotomy behind where I would put some P4HB or Galaflex, is what I typically use for that. And then you can use the same material to attach to our muscle as kind of a reconstructive model, inferior sling basically, and that can help minimize that animation deformity. I think you'd probably be able to correct her pretty well, so I'll be interested to see what you ultimately did.
So we took all that into advisement. We talked to her. The other thing she didn't like was her periareolar scar, which she was told would be invisible, and it's not. They rarely are, in my experience. We chose not to address that. She was interested in silicone gel implants. I told her my goal would be to not get an implant that was more prominent than it was now, because she didn't like the prominence that she had. So same, actually a little less profile, not any narrower, because her implants are already too far apart. Bring her implants together and pretty much correct the pocket. Two things we found at surgery that were not a total surprise. One, she had thin capsules, and so to go neosubpectoral would have been tough, I think. The other thing, her left implant was flipped over. So it was 100% turned over the other way. They were not extremely overfilled, but they were way up to the top end, and they were very firm. So we took out the implants, we did the capsulorrhaphy, we did the reinforcement of the capsules repair on both sides, and we restored the fold and brought this abdominal skin back to the abdominal wall in the lower breast. And we also went to just a full profile, which is less projection than she has, and a soft touch style Allergan implant. And in these cases, you need strength, in my opinion, and you need something that incorporates very quickly, and actually that disappears would be great, because if it can disappear or absorb and leave a strong layer, stronger than natural tissue since she has a thin capsule, that would be ideal. So that brings the P4HB into play, and we did use that.
Well, I tell you what, these are common cases, but they're tough cases, and you just did a great job with it. So congratulations, and I'm sure your patient is very happy.